Good morning, everyone. Pleasure to be speaking to you in all parts of the world today. We're glad that you could join us during the ZAP webinar series brought to you by ZAP Surgical and COVID-19. Delighted to have you join us today. As a point of introduction, I am John Adler. I'm a professor of neurosurgery at Stanford and also the CEO of ZAP Surgical. Today, we're going to be talking about, or our presenters are going to be talking about radiosurgery for brain metastasis and really trying to define what are the outer limits of what we can do today with radiosurgery in treating brain metastasis. And so the title of today's talk is, how big is too big? How many is too many? And during this talk, we're going to have our two presenters. Leading off is going to be Scott Soltys. Scott is he's a associate professor of radiation oncology at Stanford, and even more notably, my former colleague. Scott is going to lead off and be followed by Isaac Wolf, who is director of the Miami Neuroscience Center and also a long-term practitioner of the outer limits of brain metastasis radiosurgery. So welcome everybody. And the next slide, just going to tell you a little bit about how we're going to run this today. You're going to see at the bottom of your slide, you're going to see a little Q&A button. If at any time during this talk you have a question that you'd like to raise, please just click on that and type in your question. And at the end of this presentation, time permitting, we'll try to address as many questions as possible to our two speakers. So with that, I invite Scott to tell us what are the limits of treating brain metastasis today with stereotactic radiosurgery.
Good morning. Thank you, John, and I thank ZAP Surgical for hosting this webinar series. And welcome all the attendees from myself too. All please stay safe. I wish you all much health. Regarding how big is too big and how many is too many, my role in this discussion is to provide data, a data-based answer for this. Next slide, please. These are not relevant for this talk. Next. But of course, data need to be applied to an individual patient. And although any one of these metastases may be amenable to radiosurgery, it's obvious that this patient has both too many and they're too big. Next slide. So my goal is to highlight the limits of our prospective data that we may use to define too big and too many. In other words, where do the data end? And where does clinical extrapolation begin? And along the way, we'll highlight some of the current trials exploring this edge of our current knowledge. Next slide. So to skip right ahead, what is the database answer for too many? We really don't have a lot of data for that. Up until 2006, we had no randomized trial, no prospective data of radiosurgery alone without the use of whole brain radiotherapy. In 2006, the Aoyama trial was the first to have a radiosurgery alone arm in a randomized trial, and they limited the number of metastases to 4. We all know about the Yamamoto trial in 2014, or the Yamamoto prospective series. It was not a randomized trial, and that opened the door to a database answer of up to 10 metastases. Next slide, please. So I've used this slide much over these past few years, but if you look at the second column, we have multiple randomized trials of radiosurgery and whole brain radiotherapy and combinations of that. Yeah, correct this slide. And, but all of these trials, including even the Hong trial from just a few months ago in 2019, that limited patients to only 4 metastases. Next, please. You can see Yamamoto opened the door to up to 10 metastases, but that's not a randomized trial. And then beyond 10 metastases, we have no randomized or prospective data of a large series. Next slide. So let's look at Yamamoto. Many of us think it's 1 to 10, but it's both size and volume were entry criteria for this prospective registry of close to 1,200 patients. So it was 1 to 10 metastases treated with radiosurgery alone, and the largest was less than 10 cc's and less than 3 centimeters in diameter, and the cumulative volume was less than 15. So if you quickly do the math, these are largely pretty small tumors. And if you had 10 tumors, they're all quite small. That may be clinically relevant to our practice now that we routinely treat 1-2 millimeter metastases given routine MRI surveillance. Next slide. And for review, this is survival on the Yamamoto prospective registry. Those with 1 tumor lived longer than more than 1, but the key point was that survival for 2 to 4 metastases was not inferior for 5 to 10. So if you want to use data to treat 2, you can use these same data to justify treating 10 if survival is your endpoint. Next slide. So the Yamamoto are prospective data, but they're not randomized. This is an attempt to get randomized data for a similar question. So this is a Dutch multi-institutional trial. Patients with 4 to 10 brain metastases are randomized to whole brain radiotherapy versus radiosurgery alone, with the primary endpoint quality of life. This has been open for a while. I'm not aware of how the accrual is going, but hopefully we can get some prospective randomized data, at least up to 10. Next slide. So really the main unanswered question in radiosurgery for brain metastases is what is the impact of treating more than 10 mets? Next. Well, we have some retrospective data for this, and this is probably one of the largest. This is from Mike Chan's group of over 2,000 patients treated with radiosurgery alone for up to 15 metastases. And if you look at the survival curve there, it's similar to Yamamoto, where those with 1 tumor live longer than more than 1. But when controlling for confounders and multivariable analysis, there's no difference in survival for 2 to 4 mets versus 5 to 15. Another conclusion was that salvage whole brain rate was the same in both groups. Next slide. So those are retrospective data, but of course we need prospective data. This is a trial being run out of Harvard, institutional trial. Patients with up to 20 metastases are randomized to hippocampal avoidance, whole brain radiotherapy versus radiosurgery, with the primary endpoint, a symptom inventory, the MDAS-EBT. Next, please. So that was an institutional trial, but this is a currently open cooperative group trial. This is CE7, run through Alliance and endorsed by Energy. The PI is David Roberge, who I saw was one of the attendees on this conference. So patients with 5 to 15 metastases are randomized to hippocampal avoidance, whole brain radiotherapy with amantine versus radiosurgery. And it's a co-primary endpoint of survival and neurocognitive progression-free survival. So this is the same endpoint as the post-resection radiosurgery trial in 107C. So please, if you are part of these cooperative groups, please support this trial so we can get an answer. Next slide. So let's go back to the Hughes paper. One of the problems with treating many brain metastases is that the patient may have many more brain metastases in their future, and there's some data for this. Mike Chan pioneered the brain met velocity. So this is a value if you take the number of new metastases when they recur. So this is that first recurrence after initial radiosurgery, and you divide that in time and years. So if on your 6-month surveillance scan, they have 4 new brain metastases, that's 4 divided by 0.5, so the brain met velocity is 8. And you can see the number of metastases treated initially correlates with either the number coming back or they come back early. Next slide. The reason why this is important is that brain met velocity, again, this is Mike Chan's work, correlates with survival. So that's not too surprising because it's probably just a surrogate for progression of extracranial disease. But if you look at the bottom right, somewhat surprising perhaps is that it correlates with neurologic death. So if you had a high brain met velocity, then you have a higher risk of neurologic death. Next slide. So with this in mind, this is another energy trial that's working itself through the process. This is a concept. So you treat patients with radiosurgery, and at the time of the first or second round of new metastases, you calculate their brain met velocity. And if it's in that intermediate to higher risk group, they're randomized to radiosurgery with or without whole brain radiotherapy. And the primary endpoint is neurologic death, essentially, I guess, trying to flatten that curve of neurologic death that we saw on the previous slide. This is slated to potentially open at the end of this year. Next slide. So that's a database answer for too many. What are the concerns for too big? Well, they're mainly, if it's too big, then tumor control is lower. If it's too large, then toxicity may be higher. Next slide. So what is local control with single fraction radiosurgery? This is some older data, but the point still stands that as a tumor gets much above 2 to 2.5 centimeters, local control, at least in these series, is worse than if it's smaller. So what are some ways to improve local control? Well, one is to resect the tumor. Oftentimes large tumors are symptomatic anyway, and that's usually the best for the patient. And then you do post-resection radiosurgery. Next slide. An alternative option is to fractionate. These are retrospective data from Giuseppe Minetti. He took patients with metastases greater than 2 centimeters and looked, tried to control for confounders and compared those that treated in 1 fraction versus 3 fractions, so 27 gray and 3. And despite a larger PTV volume in the 3 fraction tumors, next, you can see that local control was improved with 3 fractions, and necrosis rate is improved also. Next slide. An alternative option is rather than fractionating over 3 days, you can fractionate over a longer time course. So this is frame-based single fraction radiosurgery, but staged over months. So this is from Cleveland Clinic, Lily Angela's paper. You do radiosurgery to a large met, to a dose that's not likely to control the tumor, but a month later you bring them back, the tumor's smaller, and then you give them another dose of radiosurgery, and they found good local control with this. Next slide. So that's about tumor control. What about complications? So that gets into NTCP considerations, normal tissue complication probability. I won't spend too much on this, but this is a forthcoming paper that's working its way through the various review processes. These are preliminary data. It's not finalized, but hopefully this will be out in the Red Journal, where we had 51 reports of toxicity and the data were extracted and modeled. This is great work from Michael Milano. Next slide. So too big really depends on size, location, and alternatives for the patient. Here's a patient who had a brainstem metastasis, so surgery is not an option. It was renal cell, so I wasn't convinced that whole brain or some fractionated prolonged approach would work. So we did radiosurgery. Next slide. Extrapolating from the Minetti, I did do 27 and 3, but I did 24 and 3. Next. And she's fine, 2.5 years out. Next slide. So in conclusion, too many, if you define it by where prospective data end, is at 11. And we await the prospective trials of radiosurgery alone for greater than 10 metastases. And too big is in the eye of the clinician. It's dependent on size, location, symptoms, alternative options other than radiosurgery. And retrospective data suggests that fractionation likely helps. Next. I'll end there. Thank you.
Scott, that was great. And it was very data-driven. And I think you've laid the groundwork out here for Isaac to show you why you're wrong. And for everybody who doesn't know, I think there's no more polite, respectful scholar than Scott Soltys, as you just witnessed. And there's no kind of crazed cowboy more like Isaac Wolf. So Isaac?
Yes, I'm here. Okay, Scott, great talk, very academic, but not really practical for the practicing neurosurgeon on a daily basis. So I want to give you guys a talk that's based on 30 years of experience. Begin with size. Size only matters in the bedroom. Here's an example of a patient that shows up with a lesion that is 31.5 cubic centimeters and essentially was barely ataxic. We put him on Decadron. We treated the lesion to 12 gray. It's lung. People are going to say it's not enough, especially when they come from MD Anderson. But here you see the lesion 5 months later. No problems, no increased edema, and the patient went on to live 1.5 years and died of his primary disease. Next. Sometimes you need to do surgery. So there's a patient that presented with ataxia that didn't get better with edema with Decadron. You operate on the patient and you treat the lesion beforehand. This is backwards because you want to avoid carcinomatosis. There's a significant amount of literature that says in the posterior fossa, you can get up to 66% of the patients with carcinomatosis. Treat the lesion even though it's large, operate on it, and here's your 2-year follow-up without radiation therapy or three segments of radiation therapy, which in my mind is not radiosurgery. Next. So here's a patient with 2 large lesions. Once again, on steroids, completely asymptomatic. You treat the lesion, and 1 month later, the majority of this is gone. Next. And I agree with Scott that the site is really not important. If you're using gamma knife radiosurgery, the fall off is so quick that normal brain is getting a very insignificant amount of this. The concept of worrying about edema is the opposite of our experience. We've treated well over 2,000 patients with an average of 9 brain mets per patient. And we can quickly get them off of Decadron unless they develop radiation necrosis, which has been less than 1.5% on our hands. But here you see the day of treatment, 1.5 months follow-up, 3.5 months follow-up, no brain radiation for brain mets, only using 16 gray. Next. And again, I truly believe that size is not the problem. Our rule is if the volume of the tumor is causing neurological deficits and Decadron steroids don't improve it, you need to operate. Otherwise, radiosurgery does a bang-up job. Here's 20.4 cubic centimeters at 1 month follow-ups. You can see day of treatment. The blue line shows you what was treated, what's residual. This patient went on to live approximately 15 months. Next. Now, let's go to numbers when it comes to the number of lesions. Once again, when I started this, the Pittsburgh scientific academic rules were less than 3, you could gamma knife. More than that, you couldn't. I never understood where that came from, but it clearly made no sense. And so we immediately started in 1993 breaking the rules because they didn't make sense. Here's an example of a patient with adenocarcinoma with 20 sites treated, the day of treatment, and the 1 month follow-up. Next. Day of treatment, all this edema, 1 month follow-up with 17 gray. Next. Again, day of treatment, edema, 1 month follow-up. Next. And again, showing all 20 lesions, smaller with significantly decrease in the edema. Next. John, next. And even in the posterior fossa, no problem. Next. Now, we tried to publish in the neurosurgical literature early on, but were unable to. But we eventually were able to publish in the Cancer Journal 2 studies showing that with renal cell carcinoma and with breast cancer, the number of lesions, the whole brain radiation in no way affected the prognosis. The only thing that mattered was the systemic cancer and that prognosis. Next. So here you see 65 treated sites at 1-year follow-ups. The patient alive and well at 1 year with all 65 sites treated in 1 session. Next. John, next. See before and afters. Next. Before, after, next. Next. These patients lived a perfectly normal life for 2.5 years without complications except from her original lung cancer, which she died of. Now, when you look at what is the difference between giving these patients whole brain or tomotherapy and gamma knife radiosurgery for 28 brain mets, the dose versus volume is significantly different. So the idea that if you treat more than 10 brain mets, that you're affecting the whole brain in a different manner than if you're treating 28 mets is simply, as you can see in dose volume histograms, ridiculous. This is what happens when you use whole brain, the red line, and this is what happens when you're using gamma knife radiosurgery. Next. So, results of stereotactic radiosurgery for patients with multiple breaks, Yamamoto study. No significant difference in radiosurgery-induced complications. So if you use 5 to 10 versus 2 to 4, there was no side effects that were induced by the greater metastases. Next. Does stereotactic radiosurgery have a role in management for patients presenting with 4 or more brain mets? Absolutely. The idea of using fractionated radiation therapy or 3 sessions is simply ridiculous. You do not increase the morbidity. You do not increase the mortality of these patients if you do it 4 or less or 10 or more. Next. Is this safe? All right. Is it safe to do what we're doing? So you look at 92 procedures with gamma knife for 80 patients with greater than 10 mets per patient. The answer is next. No patients who underwent gamma knife radiosurgery for 10 or more lesions with a mean dose of 8 gray experienced either acute or chronic radiation-related complications. So it is safe. It doesn't mean any difference whether you're using 10 mets, 15 mets, it's just arbitrary. As long as the patient's primary cancer is controllable, in our experience of treating over 1,500 patients with an average of 9.2 lesions per patient, we haven't seen increased complications. In fact, if you listen to Victor Levin concerning radiation necrosis from MD Anderson, he says there's little or no relation to radiation dose or radiation volume. Necrosis simply occurs by chance. Next. So we have Doug Concioca, who was criticizing us back in 1993 for being crazy, 20 years later saying what was once considered hearsay 20 years ago, when a focused procedure was used for an unfocused disease, now he's treating 2, 3, or 4 more tumors with very good controls. Next. So, like Richard Branson says, don't follow the rules. If everybody followed the rules, nothing would change. And without change, there is absolutely no progress. Thank you very much.
Spoken as a rule breaker. Very good, Isaac. Well, I just want to ask the first question, and then I'm going to present questions from the audience. But Isaac, you like to say there's almost no limits to what can be done with good radiosurgery and large numbers of brain metastases. Yet Scott Soltys presented a case up front where he said clearly whole brain radiotherapy is warranted and radiosurgery is not an option. Do you recall that case? And so
I remember it.
and so I throw out the challenge to you. Is that a case for radiosurgery in your opinion?
My answer would be very simple. If the patient has a life expectancy of greater than 3 months based on a systemic disease, we would treat that patient with radiosurgery, without a doubt. There is absolutely no evidence in our data that you couldn't do that and do well by the patient. Whatever we've been allowed to publish, John, in our data, and we have also a series with Johns Hopkins and Dan Rigamonti for melanoma and for renal cell as well. It is clear in our data, and I agree that Scott's going to say it's retrospective, but the truth of the matter is that the number of lesions has never really mattered. And when you look at the amount of radiation you're given with radiosurgery versus whole brain radiation, it's significantly less. It's just a matter of that when we started this, as you recall, you had to change every single ISO center. And so that was a lot of work. And I think that was part of the problem. Nowadays, it's all automatic, so you don't have to work so hard. So everybody's doing 20 lesions, 25 lesions, including some of my biggest critics at UCSF. But the point is that as long as we feel the patient's going to live 3 months, we think gamma knife radiosurgery is much better for the patient anyway. It's only a one-day treatment versus 2-3 weeks.
Okay. Well, I'm going to start asking a few questions from the audience. First question, what normal brain constraints do you use for fractionated or single fraction radiosurgery? I think this is for you, Scott. Do you use more stringent constraints for eloquent cortex? Or the question was a corpus callosum, but I don't think that necessarily requires any stringent requirements. So, Scott, how do you think about when to use single fraction or multiple fraction radiosurgery?
I'm more concerned about tumor control. So I invoke those Maniti data. If it's above about 2.5 centimeters and they're asymptomatic, then I will fractionate. Again, those are retrospective. As far as, I honestly rarely look at, V12s and V14s and out of concern for normal tissue complication probability, so radiation necrosis. But please look at Mike Milano's paper when it comes out. If you want fractionated constraints, Giuseppe Maniti has those too. But honestly, a lot of the tumors we treat are larger and we're beyond those constraints. I think in the era of Avastin, radionecrosis is less of a complication. Also, we have LIT, that's a good treatment for necrosis.
Okay, I have another question here. Maybe get it from both of you. It's a cynic who says, where is the evidence that any radiation treatment of more than one metastasis has an impact on overall survival or quality of life? Quote unquote, the fact that survival for 2 metastases and 15 metastases is the same is not proof that radiation is effective. Want to take that on, Isaac? Someone doesn't think you're doing anything any good.
Well, I mean, the way you'd prove that is just decide not to treat any of these patients. But when you and I both know, for example, that in melanoma patients, that prior to immunotherapy, most of these patients would die just like this individual says, whether they had 1 met or 40 mets. But our melanoma patients that we've treated with 30 and 40 metastases who respond to immunotherapy are living normal lives 15 and 20 years on. And, that data is available. So I think it's a ridiculous concept to say that radiosurgery doesn't matter whether they have 1 lesion or 30 lesions. I mean, that seems defeatist on its own. And the same thing happens for renal cell, for example. If you get a good response for renal cell, the patient can either, from whether they have 3 mets or 7 or 10 or 15, if you control the primary disease, that patient's going to survive and is going to survive neurologically intact. So I don't know how to answer that other than, you know, it's a clearly, you know, defeatist concept. I don't know what Scott thinks about it.
Scott, is there any data?
Well, that question is from David Roverge, so he would know, but I agree. You know, he said, is there, the fact that survival is the same for 2 and 15 is not proof that radiation is effective. That's correct. I think survival is not the endpoint for radiosurgery versus, you know, whole brain. No matter what you do in the brain, survival is largely dictated extracranially. So then you look at what are the alternatives to radiosurgery, and that would be whole brain, and we know there is a detriment in cognition and quality of life with that. So it's not proof for radiosurgery, it's you know, a condemnation of the alternatives.
Someone here has asked about the dose volume curve in gamma knife or linear accelerator for single met as opposed to whole brain radiotherapy. You presented some data there, Isaac, about not only how radiosurgery, gamma knife radiosurgery compared with various different types of treatment. I mean, isn't it clear that you're giving very low dose radiation to the entire brain when you're doing radiosurgery?
Yeah, I mean,
is there not good literature on this?
yes, there is. I think there's I just presented only a single slide, but the biggest point, and I think Scott would agree with this, is that the confirmation dose that you give to the normal brain versus the tumor, especially, you know, and I don't want to promote gamma knife because, you know, I'm not necessarily promoting it, but the dose drop off is so quick and so sharp that basically normal brain is getting, you know, maybe 2 fractions of radiation, of normal radiation therapy. It's, and Scott will probably bring this up, at 3 centimeters, all right, now you're getting to the point where proton does a slightly, you know, what they call D5. So at 5 grade, you know, proton therapy with a 3 centimeter lesion is doing a slightly better job than gamma knife. But when you look at the total, when you're treating a bunch of lesions in the brain, the difference between gamma knife radiosurgery and whole brain is significant. And if you're concerned about secondary effects of radiation, it's just a matter of keep doing the work. You know, when we first started, we had to change every isocenter, whether, you know, and when we were doing 20 lesions, that was a shitload of work, and we weren't getting paid any difference between 1 or 20 lesions. We didn't care. So as long as you're willing to do the work, but now with, you know, automated systems, it's not more work, it's just a little bit more time. But you really are sparing the brain.
Scott, I have a question for you. Do you agree, as I do, that it's become general practice in radiosurgery to fractionate for brain mets greater than 2 centimeters, or we can pick the exact number, instead of single fraction delivery?
Well, that gets into what type of, if you have frame-based or frameless techniques, but in general, like 2 centimeter, I'll still typically do single fraction, but around 2.5, I would do fractionated from the Minity paper. You know, honestly, in the COVID era, we try to minimize the number of visits for the patient, so that, you know, there are a lot of factors that play into the number of days they come in.
Now, that's a community standard in some locations, but certainly not in Miami. You did show some data from, or some experience, clinical experience, retrospective from Lilly, whereby they're doing this multi-session treatment over months with larger metastasis. Is that a norm in any way, Scott?
I don't know. I know Cleveland Clinic does it frequently. I don't know if, you know, gamma knife now has fractionated capabilities, so I don't know how widespread that is. Maybe Isaac knows.
Isaac, I know you're not an adherent, but, you know, do you know what's going on in the gamma knife community with ICON and larger mets?
You know, I have to be honest with you. I think that with the ICON, some people have turned to treating with multiple treatment sessions. But, you know my feeling about that. That's just financial. I mean, I just don't see, our data changing. I mean, radiation necrosis, we have slides where we can show you, 10 lesions treated on the same day to the same dose, with the same machine, obviously. And, 14 months later, one lesion has radiation necrosis and the rest are gone. How do you account for that? And as I told you, when you looked at the Harvard data, when they were, using the concept of radiosurgery versus radiosurgery plus whole brain, they simply had to stop because it wasn't more effective and they had increased radiation necrosis, but it wasn't based on size or dose. So I think it's very difficult to put your finger on that. I just think that when we looked at our data, as long as we could reverse the neurological deficit with steroids, we did not feel that you couldn't treat the patient in single dose. And our data, proves that. But, we haven't done a prospective study, and Scott can, very easily, criticize that effectively. I'm just telling you that on an experience basis, what our data showed over and over again is, what that questionnaire was really getting at, whether 1 versus 3 versus 10. For us, the primary disease is the limiting factor. And until you get control of that, you're still going to be doing radiosurgery, multiple times in order to get control of the intracranial contents.
Scott, question for you. Are we seeing more necrosis in the immunotherapy era?
Yes, there are multiple series on this, and they're all not completely in alignment, but yes, in general, you see more necrosis. Some series show more imaging necrosis, but the same amount of symptomatic necrosis, and then others show more symptomatic, and it correlates with timing. There'll be a special issue on immunotherapy in the Red Journal upcoming this year, and there will be some papers on that in there.
Isaac, any empirical experience in and around necrosis and immunotherapies?
I have to be honest with you. I don't have numbers to correlate with Scott, so I would say that I take his word for it. But I think there is a huge difference between, MRI imaging necrosis versus symptomatic necrosis. And after we've done a PET scan and proven that it's necrosis, if the patient's asymptomatic, we generally do nothing. We start Avastin immediately for 5 doses if the patient is symptomatic, and usually it's very effective.
Well, I'll argue that even PET doesn't distinguish necrosis. It's always a clinical judgment, but okay.
I agree with you. It can be difficult at times.
But your strategy, I understand. Okay, Scott, I think there's a question for you, especially in the setting of leptomeningeal disease, which I know you've got a lot of experience writing about. So the question is there any trial for neoadjuvant chemotherapy with Avastin or any other agent, and then radiosurgery?
I'm not aware of a neoadjuvant chemotherapy trial other than people are looking at immunotherapy in combination with radiosurgery. But as Isaac showed from his experience long ago, I agree. Pre-resection radiosurgery should improve multitude of outcomes. Should improve radiation necrosis. It may improve local control, maybe not. But the main benefit would be the risk of leptomeningeal disease. We are working on a trial. Stuart Burry is PI, I'm co-PI of that.
Okay. This is an all too common problem. What do you do, and kind of especially what is the time sequence that we should follow when we find a treated lesion initially responds and then subsequently enlarges? Isaac, I'm sure that's never happened to you, but what do
Actually-
you do when it starts to enlarge, 6, 9 months, a year later?
Actually, it does happen.
I know.
And, and it's a great question. So the first thing we do is, if it's around the time that we're expecting radiation necrosis, we do a PET scan. And we try not to get an equivocal answer about the PET scan. And clearly, if the PET scan shows that it is no hypermetabolism anywhere, we begin treatment with Avastin, and we do it to 5 doses. If the lesion is suspect for recurrence, we biopsy it almost always to be 100% sure. And if it is positive for recurrence, we treat it again. If we don't see any, biopsy proven, recurrence, once again, we treat it as radiation necrosis.
Anything to disagree with there, Scott?
No, I agree. I think we don't have a good, we don't have good imaging that can tell necrosis. And oftentimes it's an admixed necrosis with tumor, so then imaging doesn't help either.
Well, I'm going to ask one last self-serving question, and this is you, Isaac, with new techniques. They recommend suggested HyperArc and maybe even Zap X. Will the Gamma knife be obsolete for treating multiple brain mets?
Well, John, it's very possible. I mean, as I've said to you before, to me, the treatment of multiple mets is clearly superior to whole brain radiation in every possible way, that I can think of. And if ZAP continues on its path, then, as you know, I will stop using Gamma knife and use ZAP. Simple as that. The better the technology, the more effective it's going to be on my patients.
Well, on that note, let's sort of wrap this up. I think we've been trying to be respectful of everybody's time. There are a couple questions we may just answer offline, but I'd like to remind all of you that over the next few weeks, actually on a weekly basis, we're going to continue to have continuing lectures in our webinar series on radiosurgery, again, brought to you by COVID. So once again, thank you for everyone participating this morning. I'd like to thank the two speakers for doing a great job of presenting both the data and experience in around the advanced treatment of brain metastasis with radiosurgery. So thank you, everyone. Be safe and hope to see you soon on our ongoing webinar series. Bye-bye.
Thank you, John. Thank you, Scott.
Thank you.